Hi there, I'm Shichun Park, a dentist from South Korea. Today I'm going to talk about finding easy way of digital full mouth rehabilitation. I started on my journey in digital dentistry 10 years ago using chairside CAD/CAM solution. Along with two colleagues, I founded a company called Implant Masterclass where we provided training on effectively utilizing various digital workflows. I look forward to sharing valuable insight about digital full mouth reconstruction today. Treating the full mouth rehabilitation involves many considerations. Moreover, we often feel challenged by new digital workflows. However, as transition to digital technology is rapidly happening across all industries, I believe that learning basic digital knowledge is essential for a successful treatment. These are the visual contents you will learn in today's class. I'm sure that you will gain a lot of practical information necessary for clinical practice from this lecture. I'll briefly mention the essential basic aesthetic analysis and basic reference plans necessary for full mouth rehabilitation. Gathering proper information is crucial. I think one of the most challenging treatment is treating severely worn dentition. We will also look at the digital dentures, which are fundamental for treating fully edentulous implant patients. We can use collected information in diagnosis, surgical guide, and making temporary and final product for full mouth implantation. Mouth rehabilitation, often referred to as a full mouth rehabilitation, is a comprehensive treatment approach that addresses all teeth in the mouth. The main objectives of full mouth rehabilitation is to restore proper function and aesthetic to the mouth, ensuring that the patient can bite, chew, and speak comfortably and effectively. This process often involves a combination of various dental procedures, which may include periodontal treatment, orthodontics, endodontics, veneers, bridges, crown, implant, and more. The specific of the process can vary depending on individual case and the technology used. According to GPT-10, digital dentistry involves treating patients using at least one digital tool. However, this does not mean completing the entire process only with digital technology. Let's take a look at digital tools. Various scanner acts as digitizer that transform physical models into digital files. Remember that these models represent accurate scan models. They have a directional presence in 3D space. The CAD software handles this input data. Now, the designed prosthetics will be fabricated using additive and subtractive method. They are milling and 3D printing. These are frequently asked questions for digital dentistry. They are about the accuracy and the convenience of the information gathering. To concretize these aspects, it is crucial to understand each technical element. Let's think about accurate scanning first. Optical impression were developed by Dr. Duher in France 50 years ago. It was remarkable that not only optical impression but also the same-day prosthesis protection were achieved. Since then, intraoral scanner have made a significant progress in terms of convenience and accuracy. Do you know the accuracy of your intraoral scanner? We just say 50 micron deviation is okay. The values seem very negligible but very important to less stressful setting of installation. You can approach it with different accuracy level. Here is the level 1. If direction and platform positions are good, it is sufficient to produce prosthetics using stock attachment and cementation. Just like treating natural teeth, we can separate this into 3 segments for prevent misfit. To the next level, we can produce titanium custom abutment and the opposite cornea structure simultaneously using scan body. Higher precision levels are required in this case, so you should think of additional variables such as scan body alignment and precision milling. For non-segmented single-piece screw retained prosthetics, the highest level of precision is required. If not, frequent issues such as zirconia fractures or cylinder detachment can occur. So, how we can ensure accurate scanning? Let me propose 5 standards for accurate scanning. Since all scanners are essentially camera, it's better to scan slowly and steadily for high quality images. At this point, I want to use the term data contamination. For example, if irregularly moving mucosal tissue frequently appears in the scan, they can generate distortion of the scan. Let's take a closer look at number 2, especially specificity and notifier shortcut scanning. Scanners almost immediately determine 3-dimensional projection using point cloud during scanning. Based on this, the scan area is expanded by overlapping with the existing scan area, usually 40%. Look at the palette smooth area. That area is unfavorable for accurate superimposing. This report mentioned that an impression template can enhance accurate intraoral scanning. If possible, you should control scan area for higher degree of complexity. 6 implant is more complex than 4 implants. Digital surgical guide can be used for not only surgery but also scan template. You can achieve more complex environment using template like this. But during the scan, you should fix template to the bone to take a clear image. However, in many clinical situations, it is difficult to prepare the scanning template for all cases. At this time, increasing complexity using markers with flow region increases the speed and the accuracy of the scan. Of course, it is also okay to use small amount of contrast powder for convenience. Denture usually have so much smooth area, the scanner can get confused. It's very hard to scan. Uh, in this case, markers are very useful. You can remove it later in the CAD software. Here is an example of actual use. Just like after surgery, it is recommended to use a dual scan body scan. What is dual scan body scan? You should prepare temporal restoration and surgical guide before surgery. For facially edentulous arch, anchor pin can be used to compensate the lack of the guide stability. In this case, anchor pins were used for tissue supported area. The first scan includes the scan template and scan bodies, and the second scan includes the gums and scan bodies. Now we can use templated scan to determine implant coordinates. With the gum scan, we can determine gingival height. To get more accurate gum information, we should scan 2 or 3 days after surgery. It is crucial to set the gingival line subgingivally. Please take consider of the vocal alveolar bone loss occurring in immediate implant placement after extraction. This is the temporary restoration. The custom abutment and PMMA temporal prosthetics were made in the in-house lab. Next, what is shortcut scanning to improve accuracy? To evaluate intraoral scanner, we need a reference scanner, a model scanner. How can we evaluate the reference scanner? We can only measure precision, effect of repeatability. This diagram shows very high accuracy across multiple scans. Generally, as the scanning distance, distortion increases proportionally. Arches can have a long distance. We can edit the shortcut scanning to diminish distance. As seen in the 2x2 matrix, the framework scan did not significantly impact, and using shortcut scan resulted in less distortion than scanning only the following arch scan. Next, let's look at the difference due to scanner operators' experience. Here's JPD article for operator experience factor. They use the cadaver to simulate the oral environment. In this experiment, the model have no moving tissues. We can encounter some difficulties of scanning. The first difficulty comes from long scan body beyond the focal depth of intraoral scanner. The secondary difficulty is exactly the same scan body geometry plus smooth surface. In this study, we can find the shape of implant platform's origin and angular changes. Let's think about analog dentistry. We can make similar errors such as silicone impression, material distortion, or misplacement of lab analog. The result shows a higher the proficiency, the higher scan accuracy. Aligning using clear structure like scan bodies is advantageous. It shows important the knowledge-based experience and alignment. Please remember when overlapping, it is beneficial to focus the structures will relatively small changes and clear definition like scan bodies. Please use clear structure like scan bodies. It is very reliable. The next topic on digital tool is how to efficiently and accurately capture intermaxillary relationship. To harmonize full mouth prosthetics with facial features, facial information is necessary. Facial scanner can be a best option, but we will learn how to scan only the necessary area with only intraoral scanner without our facial scanner. This patient shows a decreased ratio from the bottom of the nose to chin compared to the other areas. The existing temporary teeth need modification in all aspects, including the occlusal plane, midline, and tooth axis. However, it can be challenging to set the vertical dimension again after removing all temporary teeth. Using existing temporary teeth, I performed constructed 3D elevation. My patient cooperation was relatively good, so it was judged to be more advantageous than vertical articulator. Method to determine BD include the distance from the maxillary vestibule to the mandibular vestibule. Then you can use facial ratios, and you can use the pronunciation or swallowing, and you can use the resting position. The moment the lips lightly touch when closing the mouth is the resting position, and you can subtract 3 millimeters from this. It is a vertical dimension. How we can using temporary teeth and align them as shown in the right picture. Scanning begins with the temporary teeth in place. Since mandible has no reliable scan areas for overlapping, it is advisable partially removing temporary teeth before completely taking them out to ensure good overlapping during the scan. If you want to use scan bodies, you can insert the scan bodies, replacing abutment. For the maxillar, scan 2 aligns with the scan 1, and scan 3 aligned with the scan 2. If the plate structure helps with alignment, because they usually have a very complex structure and complex geometry. Uh, in this case, the scan 3 can be directly aligned into the scan 1. Now the scan files are properly aligned in the desired position. The files are aligned with the cross-channel mounting, and the facial T-zone scan using oral scanner is aligned with the oral scan. As a result, the midline and teeth were corrected, although the midline of the facial face and the prosthetics are not exactly aligned. It is more important harmony in tooth axis, and these teeth axis correction compensate somewhat extent. Now look at a case where vertical dimension was increased using vertical articulator. For patients with unstable mandibular movements, it is preferable to capture the intermaxillary relationship or stable position using vertical articulator rather than recording by increasing the vertical dimension in the mouse. In edentulous case, long scan bodies can be inconvenient, so using low profile scan bodies like healing scan abutment is very advantageous. We can use pre-extraction information for mounting. Immediately after surgery, we can scan with the healing scan bodies. If the surface is too glossy to scan, you can try contrast powder and sandblasting. Using a vertical articulator and a full mouse library, the design can be done more easily. The full mouse library shells were arranged in the mesh mixer and then imported into CAD software for morphing. After that, you can finish your design with minor adjustment of occlusion or teeth shape. The temporary prosthetics were connected as a single piece to ensure cross-arch stabilization before complete osseointegration. Later, you can segment it into 3 pieces. The temperatures were used without significant discomfort, with minimal occlusal adjustment for 1 month. I'd just changed material from PMMA to zirconia without any design change. In the anterior section, the screw hole was removed for aesthetic reason. Full mouse implant may seem challenging, but approaching them in segments lowers the required accuracy level, reducing difficulty and chair time. Now let's look at the method of obtaining 3D from the natural dentition. You can take scan during implant surgery. Although the residual teeth are almost hopeless state due to advanced periodontitis and dental caries, using the remaining dental information can be very advantageous. While performing in the surgery, I have performed the scan during the procedure. You should pay attention to the mobility of the teeth. The custom abutment and PMMA temporary prosthetics were installed the day after surgery. Considering the existing occlusal plane and midline of maxillary anterior teeth, Patient discomfort was minimized. As seen in the photo, the dark color of abutment is visible in some abutment. Discoloration of natural teeth or dark color of titanium abutment can be blocked in various ways. The first method is using opaque liquid for masking. This process can reduce transparency, so it should be done carefully. Next is using opaque cement for aesthetic prosthetics. To predict anticipating the outcome, we can use training paste. Next one is anodizing. The anodizing can change the color of titanium abutment depending on voltage used. There are so many studies about anodizing and color change. Some say the color difference is negligible, but it's generally known that gold color is most effectively prevents brightness reduction. Factors like zirconia thickness and margin locations should be considered. It is wise to mix and match multiple methods. Using temperatures allows predicting and simulating these aspects despite different material properties. The designed prosthetics fits relatively smoothly. Although PMMA has low hardness, it is not an easy material to milling. For final product, in addition to milling, the variables due to sintering, zirconia sintering should be considered for zirconia. It is important to study various theories and strategies regarding occlusion in full mouth treatment and apply them in visual treatment. When using vertical articulator for full mouth treatment, the guidance of design influence more than inside guidance. We are processing custom abutment using connection pre-milled titanium blocks with 5-axis milling motion from Arum Dentistry in-house. Metal processing is not easy, and processing this foam requires high speed power, proper calibration, and precisely repeatable jig mounting. Different companies' CAM software can be used with the same machine. In the past, making diagnostic wax up using plastic models required a lot of effort. There were significantly differences depending on the technicians and dentist capabilities. However, I think it is much smarter to invest our efforts and time onto overall arrangement and occlusive curves and functional analysis than individual tooth morphology. Pre-selected library matching the patient facial and arch condition can be individuality. Using this resource helps patient understand the treatment and also greatly assist the dentist. We can establish the reference planes in the scan, then we can align a full arch library to these planes. This is very useful and saves a lot of time because only minimal adjustments are needed. This is the first design after milling. Deciding the appropriate occlusal plane and vertical dimension is not an easy task. We should evaluate and adjust it with temporary restoration. Sometimes it is necessary to modify the straight MUA to an angle type MUA or segmented custom abutment due to cam and milling machine limitations. To construct a virtual patient, we need information on face and oral scans. Using 2D photos as they are is very simple. However, be careful as they may be errors depending on viewpoint of angle of the photo. Even 11 years ago, a single photo was used for smile design, although the exact prediction was impossible. It helped us choose the right teeth library and match the patient, such as triangular, round, square shapes library. Facial scanners with a separate camera module are now available for mobile devices and desktop facial scanners, significantly increasing convenience.